So let's look at this very well. Right here is your common femoral artery right here, okay? So any pain I'm gonna have would not include this area. Will include anything distal to that, which is gonna be your thigh, your leg, and your foot. Anything distal to that. So what about if I have an SFA, superficial femoral artery, which is right here, okay? Go back. Okay, this is your superficial femoral artery right here, okay? If you have an occlusion of the SFA, okay, anything distal to that is going to be a problem, okay? So if they say, you know, you have an occlusion to the proximal SFA, right? Then your pain will be upper two-third, right? If it's the distal SFA, your pain will be mid. This is wrong. What happened here? If you have an occlusion to the SFA here, distal SFA, then it's going to be pretty much your calf muscle. Okay, the only one that I think you should remember is when you have an occlusion of the aorta of the aortoiliac area, you're going to have a bilateral claudication. Any questions about this? All right. Make sure you remember that. All right. So the next one I want to cover real quick. We discussed that already. I'm not going to go into that because sick of time. I'm watching my time here. I'm sorry, guys. Sorry. I just want to get to some area that I think is very important. Okay. Bucker's test, right? Which foot do you think has the problem? The right one or the left side?
Left.
The left, right. When you have a venous problem, if you look at this one, it's like bright red, right? Whereby your venous is almost like, how do I explain it? It's almost like purplish red, okay? Purplish red. Okay, so when you see that purplish red like that with the venous issues, when you elevate them with the Bucker's test, the foot will turn pretty much normal. But when you put them down, you see this, purplish red kind of looking color, right? And this comes back really fast, within seconds, less than 5 seconds, which has been shown here. Venous insufficiency, less than 5 seconds. Arterial problem, more than 20 seconds. Make sure you remember that. Also, with your Bucker's test, you could use to differentiate between cellulitis and other condition. With cellulitis, when you elevate it, it's red. When you put it down, it stays red. So that's the only time the foot is going to stay red, when it's elevated, when it's down. The only time, cellulitis, okay? When it comes to Charcot, okay, with Charcot, when you elevate it, because you have a vasodilatory problem, when you elevate it, the foot turns normal. When you put it down, it turns bright red, okay? So that's how you differentiate between cellulitis and your acute gout and whatnot, okay? I won't go into that. I'll keep going. Okay. Can anybody answer this question? If we get this question right, I'll be really impressed. This patient, we're using a Bucker's test. With the leg elevated, the left side is affected. With the leg elevated, it turns normal. When the foot was put in dependency position, it becomes rubber cyanotic in appearance, or it looks like this, purplish red color. What could be your diagnosis based on this first two description?
Some type of venous insufficiency.
Right, exactly. Venous insufficiency. That's exactly what I just said. Venous insufficiency. They will look a little cyanotic. They'll look like, purplish red color. Venous insufficiency. Perfect. But what if I tell you this patient's foot 3 weeks ago, right? It was red hot swollen. And now it's cyanotic. is cool and sweaty. What's your diagnosis? I'll give more clue. This condition usually occur after injury or after surgery.
Cribs.
That's right, Crips. Do you guys get that? Crips. You should know Crips very well. They ask questions about Crips all the time. Okay, so Crips. So basically, initially, it's going to be red hot swelling, just like an infection. But the biggest difference is they are so hypersensitive. You touch them like this a little bit, they're going crazy. They are very, very sensitive, red hot swelling in the initial presentation. And later on, weeks later, it will be cyanotic, cold, sweaty. When you elevate them, it turns regular. When you put them down, it turns this purplish red color. Okay, Crips. Okay, so with Crips, basically, what happened is that it's an abnormal firing in a sympathetic system, leading to chronic inflammation and pain and swelling. But again, the mnemonic you should know is STAMP, right? With STAMP, you have hyperalgesia. They're very, very sensitive. They have changes in their skin. You can see it right here. They are swelling. They have cool feet. The late stage of this condition, this patient will have some kind of muscle weakness and reduced range of motion, like stiffness and severe pain. Okay, so type 1, Crips, is soft tissue and bone. Type 2 is nerve. Again, this one you have to know. Stage 1, stage 2, stage 3. Stage 1, basically you have the red hot swelling foot, and later on will turn into that cyanotic sweaty feet. Stage 2 is when the muscle has been affected. Okay, stage 3 is pretty much when you have ankylosis and contracture. There's something called pseudosudex atrophy, and what it is that you're going to see this spotty osteopenia right here, or they call it patchy osteopenia, right? When you see that, and they see a patient just had surgery 6 weeks ago, that is your pathognomonic for Crips. And Crips usually you see in like 6 weeks after surgery. Okay. Now, treatment for Crips, please remember this: vitamin C therapy. Do me a favor, write these down. On the board exam, if you see anything close to Crips, your answers will always be vitamin C therapy. Vitamin C therapy. Don't say pain management. That's for later. Don't say steroid. Use it later. Tension unit, part of therapy. Sympathectomy. That's for later. Nerve blocks. That's for later. Psychotherapy. Okay. Your answer is always vitamin C and therapy. Therapy. No surgery. Therapy. Okay. Oh, definitions. You should know this. Petechia, what does that mean? You know, when you have a bloody tinge, 1 to 2 millimeter, okay? Purpura, more than 2 millimeter. Telangiectasis, when you have a small venule that is more than 1 millimeter in diameter, okay? 1 millimeter in diameter. So you should know your definitions. And when it comes to your varicose veins, it's dilated veins, 30 millimeter or more, okay? Okay, so petechia, 1 to 2 millimeter, purpura, 3 millimeter, ecchymosis, 1 to 2 centimeter, telangiectasis is 1 to 2 millimeter. Or less than 1 millimeter, less than 1 millimeter, I apologize. Telangiectasis is less than 1 millimeter, less than 1 millimeter. This is 1 to 2 millimeter, this is more than 2 millimeter, this is less than 1 millimeter. Okay, an example of telangiectasis is your spiral angioma. Okay. And let me go to the main thing right here. How am I doing so far? Is this helping, guys? Is it helping you guys a little bit? Refreshing a little bit?
Yeah.
Are we good? Okay. All right. So if you guys remember, we talked about this. If you can't feel pulses and you have atrophic skin, right, you want to use your handheld Doppler first. If it's monophasic or biphasic, you want to go ahead and order your non-invasive vascular studies. Okay. Now, your non-invasive vascular study, we'll talk about that in a minute. When it comes to your handheld Doppler, the most important thing for your exam, you got to angle this 45 to 60 degrees. Not 90, not 0, 45 to 60 degrees. And don't put too much pressure on it. Okay? That's easy. Edema, you guys know that already, right? When it comes to edema on the exam, if they give you something like this, remember this, if it's 2 millimeter of depression divided by 2, you get +1, but if they don't give you that, the best way of really coming up with your pitting edema is to use your time, seconds, okay? So if it bounces back so fast, okay, that's, your 0. If you depress it, and disappear rapidly, is +1. If it's 10 to 15 seconds, +2. 1 minute is 3. 1 and 2 minutes is 4. Just make sure you know both of them. The easier way is to just divide it. But again, they don't give you that. Use the seconds. Okay. And don't forget, when it comes to check where you are pitting edema, the dorsum of the midfoot, medial ankle, and the shin. So pitting edema and non-pitting edema. Non-pitting edema, you want to say things like your lymphedema. What else? I want to show you something real quick. If I could find it, I can't find it. Sorry. I can't find it. Maybe it's not here. I apologize and go back there. Good. So your lymphedema, okay, is one of the best examples for non-pitting edema, okay? And there are other things also that could lead to non-pitting edema. Does anybody know? You guys remember lipedema? Your lipedema could also give you non-pitting edema. There's one more. This thing is caused by a patient with Graves' disease. They have the orange pale skin appearance. What do you call that?
Myxedema.
Myxedema. Exactly. So those are the 3 main things that you should know. Myxedema, your lymphedema, okay, and also your lipedema. They will give non-pitting edema. But when it comes to the difference between non-pitting and pitting, okay, is your stemma sign. Okay, you guys remember stemma sign? A positive stemma sign is when you press on the base of the second toe, all right, and you could compress and you can't compress it. That is what's called positive stemma sign. The way to remember this is that the stemma sign was developed for lymphedema. People that have a positive lymphedema. So if you have a positive lymphedema, you will have a positive stemma sign. Positive lymphedema, positive stemma sign. Okay. But if you have a negative stemma sign, that means you could compress it. You could compress the base of the second toe. Okay. If you have a positive stemma sign, that means you cannot pinch the base of the second toe. You guys remember that? Yes?
Yes.
Good. Another thing that you see most of the time when it comes to positive stemma sign or lymphedema, especially when you have an advanced lymphedema, is something called a cobblestone appearance. Okay? And it looks something like this, cobblestone appearance. Okay, that's the typical lymphedema. Okay, I won't go to that. Keep going. DVT, you guys know DVT very well, so I'm not going to go into depth about that. Just remember your virtuous triad. I use my mnemonic HIV. H is your hypercoagulability. Your I is your endothelial injury, and your V is your venous stasis. Okay. Don't forget this. Your omen and Pratt sign, Pratt, okay, Pratt, okay, PC, compression of the calf. So when you compress the calf and it's painful, that's your Pratt. When you just press the foot, that's your omen. These 2 tests right here, they are not sensitive and they are not specific. But again, they test it all the time on the board exam. Don't forget, I am clotted, causes of DVT. Thrombosis, I think that's what you should know. With thrombosis, This is what they ask you most on the exam. A patient that have factor V Leiden, that means they're going to have DVT. Patient that have protein C and protein S deficiency. Remember, protein C and protein S are needed for the function of heparin. So if it's deficiency of protein C and S, guess what's going to happen? You're going to get DVT. Antithrombin 3, not antithrombin 2, not antithrombin 1, antithrombin 3. So these are the things you have to remember on the exam that might get you. Polycythemia, that could get you also. Just make sure you remember this. Splenectomy, that could get you also. Pregnancy, smoking, all this could lead to DVT. Let's keep going. Oh, this is very important. True or false? If I order D-dimer and the D-dimer is negative, right? Can I have a DVT? Anyone? Anyone? I'll call names. Sinai, are you still here? I guess she's not here. Mina,
Yes, Dr. Sam.
if a patient has a negative D-dimer, what are the chances of that patient having DVT? High or low?
If it's negative, it's low because the D-dimer is used to screen.
That's right. You guys should know that. So with D-dimers, okay, if your D-dimer is negative, you don't have DVT. It's impossible. You just don't. But if your D-dimer is positive, it does not rule out DVT. It could be anything else. It could be pregnancy. It could be something, okay? It could be cancer, right? So just because you have a positive D-dimer doesn't mean you have a DVT, right? But if you have a negative D-dimer, you do not have a DVT, okay? And if your D-dimer is positive, then the next thing you have to do is to do ultrasound. Very important. Right here. Is Karen here? Karen? Karen is not here. Okay. How about Andrew Ayad? Are you here?
Yes, I am.
Hey, Andrew, look at this right here. This is they call it the B mode when you're talking about ultrasound. This is a B mode, and we are using this to evaluate the great saphenous vein. Okay, sorry. This is this is a deep femoral artery. Sorry, it's deep femoral vein. So it's a deep femoral vein right here, and we are compressing it. Okay, is this compressible or non-compressible? What do you think right here?
I want to say it's non-compressible.
So does that mean this patient has DVT or no DVT? What do you think? Tanya, what do you think?
Hey, Dr. Sam. Well, so there is something there you can say. So
DVT or no DVT?
I think DVT.
Right. So that's DVT. So remember, your vein is compressible. You could compress it down. If your vein is not compressible, that means you have a DVT. Okay. DVT treatment. The best initial treatment is to give low molecular weight. Example is enoxaparin. Okay, low molecular weight. Okay, and you want to treat them at least 3 months, minimum 3 months, maximum 6 months, or until the clot is completely gone. So, but you have to just remember this. I'm telling you, they love this kind of question. When DVT, what's the best treatment for DVT? Initial treatment. You want to, the Coumadin is fine, but initial, you want to do low molecular weight, and you want to treat them for at least 3 months, minimum 3 months. I'll discuss that later, sake of time. So PE, a patient could develop PE. How do you know? If they have DVT, they have shortness of breath, tachycardia, and pleuritic chest pain. People with tachycardia, pleuritic chest pain, and shortness of breath, those three symptoms definitely means the patient has a PE. Okay. And don't forget, on the exam, when you see something like Hampton hump, Western mark sign, okay, and they have shortness of breath, pleurisy, and tachycardia, just start thinking of PE, okay? What is the best way to diagnose PE? Anyone?
CT angiography.
CT angio. And also on the EKG, which is not that common, but in case you see these, there's something called the S1Q3T3. This right here, you should know that is pathognomonic for PE, pathognomonic. Okay. So I want to teach you something. The best, okay, diagnostic test is your CT pulmonary angiogram, right? If the patient is allergic to iodine within the angiogram, you do a BQ mismatch, okay? If the CTA is not clear or BQ mismatch is not clear, then you want to use pulmonary angiography, okay? And again, the treatment for this, again, look at this. Low molecular weight heparin. Don't forget that. That's your first initial. So there are other things for DVTs. If you guys remember the phlegmasia albadolens, phlegmasia ceruleus dolens, and venous gangrene, okay? Phlegmasia albadolens pretty much means white leg, which is right here. So these are complications of DVT, right? A patient has DVT, on their leg. If the superficial, okay, venous system is spared, then what's going to happen is that you're gonna get a white leg, like I can see here. And basically that just means that the artery is in spasm. So white leg means phlegmasia albadolens, right? When it becomes blue, that means your superficial, your deep, everything is occluded, okay? And there's no outflow. That's your blue leg. Blue means cerulea. And if you don't take care of this was a venous gangrene. Phlegmasia ceruleus dolens is a medical emergency that could lead to compartment syndrome, okay? So basically, when you have a patient that have acute iliofemoral DVT, okay, when you have iliofemoral DVT, what will happen is that you could develop albadolens, white leg. If you don't take care of it right away, that could lead to ceruleus dolens, blue leg. If you don't take care of it right away, that will lead to venous gangrene, okay? So the main thing here with the venous gangrene is how do you differentiate between venous gangrene and arterial gangrene? Okay. With venous gangrene, right? Basically, you have a DVT. That's number one. Okay. You have a DVT right here. That's this triad of a DVT. Also, you're going to have a palpable or palpable arterial pulses because your artery is not affected. Nothing is wrong with the artery, just the vein. The venous system is occluded. So you're going to get ischemic DVT, you're going to get gangrenous changes. The most important thing is you have pulses that's available. Okay. So anytime you see a gangrene of the foot, that gangrene could be caused by arterial or could be caused by venous. If it's venous, you have ischemic DVT and you have some kind of circulation. If it is arterial, you have no circulation. Okay. I'm going to just rush. Let me see, what am I missing? I'm going to just miss this. I want to go over what's really important here. I want to go over this real quick. And we'll do some questions. Okay. Before I go into that, let me just discuss this real quick. So much stuff here. May-Turner syndrome. I guess you guys remember that. May-Turner syndrome just means that you have left iliac vein compression. And what's really compressing it? The right iliac artery. So the way you're going to remember this is that most of the problem that's really happening when you have DVT is really happening to the left side most of the time. So on the left side, because of the anatomy, because of the right iliac artery is always on top of that, okay, on top of the vein. So it's always on the left side. So it's always your left iliac vein that is compressed by the right iliac artery, okay, against the fifth vertebra, okay, and that will lead to DVT. Non-pitting edema, remember we talked about the lipedema. Lipedema does not affect the foot, okay, it does not affect the foot. This is what we're talking about before, pretibial mixed edema caused by Graves' disease, hyperthyroidism, orange peel appearance, non-pitting edema, congestive heart failure, can lead to bilateral, edema, renal problem, bilateral edema. These drugs, you should know this drug, calcium channel blockers, NSAID, corticosteroid, sex hormones, and other drugs, they could all lead to edema, okay? The gator area is pretty much the area below the calf area and also above the ankle, okay? That's called the gator area, and that's where you're gonna have a lot of hemocydin deposit as being shown here. So, what is the best treatment for this wound? Anybody want to guess? Hemocydin deposit, gator area, ulceration.
Compression.
That's right. Compression. Beautiful compression. Okay. Again, take a picture of this, go and review it. I can't teach you that. But one thing I want to say is the small saphenous vein drains into the papillary vein. The great saphenous vein drains into the femoral vein. You just should know that. But the rest of it, just go memorize it. You should know how a DVT will travel from the foot all the way to the lungs. Okay, make sure you know that. I'm not going to ask you this question, but this is called corona phlebecta. Basically, when the perforating veins are incompetent, that will lead to corona phlebecta. You guys know this already. I'll skip that. Atrophic Blanchard. Atrophic Blanchard is when you have a venous ulcer that heals, and they have these white patches. See these white patches here? These white patches are very painful. Very, very painful. Okay, so anytime you see atrophic Blanchard, that just means that you have venous insufficiency, a wound that is healed, but they're extremely, very, very painful. Okay, Klippel-Trenaunay syndrome. What exactly is that? Basically, these are patients that have varicosities, okay, and they have this port-wine lesion. See these port-wine lesions? So anytime you see varicosity plus port-wine lesion, that's Klippel-Trenaunay syndrome, okay? FYI. All right, good. This is the main thing I want to focus on today, and I'm going to go into questions. When you have your non-invasive vascular studies, your ABI, toe pressure, microcirculations, when you have microvascular disease, small vessel disease, toe pressures, TBI, TCON, skin perfusion pressure, which is you use laser Doppler. Okay, these are the things that measures your microcirculation. Also, there's something called the infrared rate tomography. Also could tell you your local perfusion also. But the main one are your SPP, TCOM, and your toe pressure. Okay. On the exam, what would they ask you? Let's keep that. Let's keep that. Let's keep that. You guys discussed that already. On the exam, what would they ask you? Toe pressure. Please do me a favor. Take a picture of this. Toe pressures in any toe pressure above 55, okay, is good for healing. Okay. Any toe pressure below 30, all right, is your cuticular ischemia, severe PAD. And on the exam, that's what they will ask you. Or toe pressure below 30 is what? Cuticular ischemia, PAD. You need about more than 55 of toe pressure to get some good healing. Okay. In diabetic, okay, anything below 55 is horrible. Okay. So the magic number for toe pressure is anything above 55 will likely heal. Anything below 30 is PAD. Write this down. Remember that. When you have a calcified vessel, most of the time, this patient has neuropathy. Okay. So diabetic neuropathy is also equal to calcified vessel. Okay. Anytime you see a patient with diabetic neuropathy, please, I beg you, think calcified vessel. Stay away from ABI and go to your microcirculatory testing. Okay. TBI. Please memorize this. Our normal TBI is 0.7, above 0.7. Please memorize this. Above 0.7. Above 0.7. Okay? Above 0.7. That's your normal TBI. They will ask that question. They always ask that question. Okay? And anything below 0.35 is your critical limb ischemia, severe PAD. You have to just know that. You have to memorize that. I don't know how to teach you that. You have to know these numbers. All right? Okay. I need a volunteer. Chilara, can you help me out if you don't mind?
I can. I just have the hiccups right now.
Okay, don't worry about it. I'll call somebody else. Sorry.
No, it's okay.
Okay. So if you have a patient that's got a ABI, right? And the ABI is normal, and the patient has intermittent claudication, what is the best non-invasive vascular study for that patient?
An exercise API.
Beautiful. What about this patient here? This patient has a, incompressible artery. Can I use segmental pressure for this patient?
No, you want to do like toe pressures or something?
Exactly. Toe pressure, your microcirculation. Remember that anytime you see calcified vessels, okay, microcirculations, then you want to do your toe pressure, TBI, your SPP TCOM, and obviously you want to do PVR also. PVR is okay too to do. Okay. So you could do PVR on this, you could do toe pressure on this. See this toe pressure above 50. I like toe pressure above 55. Above 50 is fine too. Above 50 is fine. 55 is even better. Segmental pressure. Segmental pressure is same thing as ABI. It's just that you're doing the multiple layers. Okay, so stay away from segmental pressure and ABI if you have calcified vessels. And the best test is your arterial duplex. That's your best test. Thank you, Trilara.
Yeah, thank you.
So again, segmental pressure. Stay away from segmental pressure if you have calcified vessel. This right here, you have to memorize. Our normal segmental pressure between limb is 20. Between limbs is 20. So if you go down one limb, it's 20. Between this segment and this segment is 20. Between this segment and this segment is 20. That's normal. Okay. If you go between thigh, between legs, between the ankles, it's also 20. Anything above 20 is mild disease. Anything above 30 is moderate disease. Anything above 40 is severe disease. Okay. Again, we talked about this already. ABI and your PVRs. How do you differentiate between PVR and arterial duplex? With arterial duplex, you're going to get that reverse flow. Remember that reverse flow? Okay. And that's where you're going to have that one peak, one another peak, and also a peak. Okay. A bump, and a bump. So we have 3 bumps, that's triphasic. If you have 2 bumps, that's biphasic. We have 1 bump, that's monophasic. The main thing you're looking for with your Doppler study is something called the baseline. If you have a waveform that's going below the baseline and forming a bump, okay, that is your arterial duplex study. With your PVR, you're going to see that diachronic notch. Okay, like right here. 1 bump, on a bump, triphasic. 1 bump, on a bump, and nothing else, biphasic. Bump, monophasic. It's not worried about that. Don't worry about that. They're not gonna ask you that. Get that. They're not gonna ask you. They're not gonna ask you. Oh, they're gonna ask you this question. Before I go to that question, let me ask a question. Guys, what do you think about this one? You think this is monophasic, biphasic, or triphasic? Let's see. Do you have a bump here? Yes. Do you have a baseline? Yes. Is it going below? Yes, a bump, and then on a bump. This is triphasic. How do I know what the velocity? Look at the amplitude. This is 120. Okay. All right. So this, they're going to ask you a lot. Okay, you notice, anytime you have stenosis, where you have the maximum stenosis, that's when you're going to have the highest velocity. And after that stenotic area, the higher velocity, you're going to have the lowest velocity. So this right here, you could have a velocity that's like 500. And after that, it could go to like 30 or 40 or 0. Okay, so you will slow down. And the reason why that is because you have turbulence flow into the stenotic area, causing increased velocity. And as it's coming out, it's taking so long for it to come out. So you have a little bit of drop. So basically, you have low amplitude and you have slow upstroke, and basically you have a low velocity. So they're going to ask you this question. They'll say something like pre-stenotic, meaning before the stenosis. Pre-stenotic, stenotic, and post-stenotic. What's the velocity? So pre-stenotic, the velocity will be high, but won't be higher than the stenotic area. And post-stenotic, it will be low. So you should know that. So the way they're going to ask you is pre-stenotic, what kind of flow you're going to get? So you're going to get that laminar flow until it gets to that area where you have stenosis, and that's when you get a turbulence flow. When you get to that stenotic area, you're going to get that severe turbulence flow and a very high velocity. And afterwards, you're going to get your very low flow. Okay? All right, I'm not going to forget that. Okay, I need a volunteer. Only Chin, are you here? How about Alexia? Alexia, are you here?
Yes.
Hi, Alexia, how you doing?
Good. How are you?
Good. So let's look at this waveform together, okay? Do you think this waveform right here or right here, which is the same thing, by the way. Let's look at this one. Is this waveform PVR or duplex study?
PVR?
Why do you say PVR? Let's look at it together. Let's see. Upstroke, yes.
Yes.
And it's coming down. Look at this line. What is this thing here? Is that baseline?
Yes.
Is it forming a hump in the bottom?
Yeah.
What do you think this is? Duplex, right?
Yes.
It's a duplex. All right. So if you look at it, it's going up. If you go below the baseline, it forms a hump. That's your arterial duplex study. Okay, one hump, second hump, and a third hump. This is triphasic. If you look right, this is monophasic. All right. So again, look at the baseline. Let's go to the next one. I'm gonna stay with you. Okay.
Okay.
Okay. What about this one? Let's look at this one together. Okay. Let's go and see. What do you think?
Triphasic?
Is this PVR or duplex study?
Duplex?
How do you know?
Oh, well. It's arterial.
I know, but you're right. It's an arterial duplex study. You're right. You're correct. But what gave it away?
It has the 3.
Exactly. If you look right here, you got 3 bumps, and it's going below the baseline right here. So a bump here, a bump here, and a bump here. Alexa, I'll stay with you real quick again.
Okay.
What about this one?
Duplex.
Why is it a duplex? Look at this is the waveform right here. This is the waveform right here. This is the second one. So it stops. Let me go back. This is the first waveform. Boom, boom, and it stops here. That's the first one. Second one. But look at this one. This is the first. Let me draw it out. Let me see it.
Oh, no, that one's different. Yeah, it's different.
Let me draw it out. I can't draw it. That sucks. I can't draw it. You won't allow me to draw it. Well, I could draw it right here. This is very important. Draw right here. Okay, good. Okay. Okay, good. So let's look at this. So this is the first waveform. Upstroke, downstroke, and diastolic, and that's it. Bomb. This is done.
Mhm.
That's done. It's the next one. Done. Next one. Done. Now watch this. Let's go to the next one. Not going. Oh, it's doing the line everywhere. Not good. All right, so Alexa, look at this. That's not the line that I want. Let me erase. No. Okay, erase. Thank you. Let me do it again. This is very important. I'm going to spend some time here. This is upstroke, coming down. This is it. That's the first waveform. Second waveform. Okay. So let's say if you take a look at this, this is your ultra duplex study, right? So if you look at it, you have the first ump, the second ump, and the third ump. Okay. And this is going below the baseline right here. And that's your first wave right here. If you go to the next one, delete. All right, if you go to the second one, which is this one right here, let me draw it out for you. This is the first wave right here.
Mhm.
Do you see any hump in the bottom?
No, it has dichrotic notch.
Thank you. Exactly what I'm looking for. It's got diagonal notch. There's no hump in the bottom. So the first wave, when you go to that cycle, there's no bump, there's no hump in the bottom. So when there's no hump in the bottom, unlike the other one I just showed you, that is your PVR. Okay. And these are the things that they're going to be testing you on that you should know. Okay. All right. So does that make sense?
Yes.
Mina,
Yes, Dr. Sam.
that makes sense?
Yes.
So let's do this one. Valencia, I'll go back to you again. Okay. Let's look at the wave. Wave is going up, it's coming down, and it's going up. And that's it. Stop. What do you think?
Duplex.
That's right. That's right. Good job. That's right. That's right. Valencia, I'll stay with you again. Let's start with this one. It's going up, systolic upstroke, systolic peak, systolic downslope, dichrotic notch. That's it. Done.
PVR.
Right. And there's no ump in the bottom. Exactly. So that's how you kind of differentiate between your ultra duplex and your PVR. Make sense?
Yes.
What about this one, Valencia? Let's do it together. Wave is going up. It's coming down. Oh, lump here. A lump here, and it's done.
So it's duplex.
That's right. Good job. Absolutely. Excellent. That's it. Okay, let's keep going. TCOM. With the TCOM, okay, basically, study shows that more than 30 would likely to heal, but that's horrible. It's probably not going to heal. You want more than 50 mmHg. On the exam, if they ask you what's considered normal, more than 30 is normal, but what's going to heal? More than 50. Same thing as the toe pressure, more than 50. So toe pressure, TCOM, more than 50. Again, this is your skin perfusion pressure, okay? Microcirculation using laser Doppler. So if you have a calcified vessel, it's not going to affect it, you know. And basically what this is like, it is telling you how much, what's the pressure that is being generated, you know, from, you know, a compression of a vessel, okay? Same thing with SPP, TCOM, SP, the same thing. More than 50 is good for healing. More than 30, they say it's probably going to heal. Angiosomes, make sure you know your angiosomes, okay? I don't have to go over that. You guys know that already. Go over your angiosomes and know which angiosome supplies an area. For example, the angiosome that supplies the heel, okay, is your PT and your peroneal, both together, okay? Your heel is your PT and your peroneal. So you have to just know that, okay? Don't worry about that. Calcified vessel. Okay. I'm almost done. By the way, I'm almost done. I'm going to some questions. I'm almost done. When it comes to treatment of PAD, the best way to treat PAD, the first initial treatment is lifestyle modification. On the exam, don't forget lifestyle modification. If the lifestyle modification does not improve the symptoms, the next you want to do is to place the patient on penicillin, okay, or Trental, or silazazole, which is Plantal. Okay, silazazole is what is recommended by FDA for the treatment of intermittent claudication. You could use penicillin also, but FDA have shown that the results not as good as silazazole. So silazazole is the number one treatment for intermittent claudication, followed by penicillin. What is the problem with silazazole? Anyone? Can I use silazazole in a patient with CHF?
No.
No. So never use silazazole in a patient with CHF, ever. Okay, so what I'm trying to say with PAD, the first thing is want to do lifestyle modification. Then you want to put on medication if the pain is still there. Your intermittent claudication pain, your silazazole is number one, followed by penicillin. But you want to make sure you do not give this patient, give this medication to patient with CHF. Okay.
Also, the first time I have a question for this medication. Is another contraindication like bleeding disorders because of platelet aggregation, or am I mixing them up?
There's no really bleeding disorders with this medication. The one they say, you're going to get the flexibility of the vessel and increase circulation to the local area is penicillin. There's no really bleeding disorder, but it could lead to abnormal bleeding. Yes.
Okay, thanks.
Yeah. Again, what are the last modifications? Smoking cessation, exercise. Listen to this. Smoking cessation and supervised exercise, weight loss and everything. All this stuff, right, will help increase your walking, but has no effect on ABI. No effect on ABI. The only time your ABI will get better, okay, is if you do some kind of revascularization, okay? All this stuff right here will improve your walking, but it's not really going to affect your ABI, okay? Cholesterol medication is great. Antihypertensive medication is great. Now, do me a favor, listen to this. Write this down. Very important. When it comes to a patient with PAD, aspirin and Plavix, and the name for Plavix is what? What's the generic name for Plavix? Anyone? Make sure you guys have been studying. Anyone? Please answer.
Clopidogrel or something like that.
Clopidogrel. Okay? Clopidogrel. So aspirin and clopidogrel. Studies have shown that aspirin and clopidogrel has no effect on PAD. Zero. But it's very, very helpful in treating patients with CAD or preventing the patient from dying with CAD or CAD complication. So let me repeat. Can you use aspirin and Plavix or clopidogrel to treat a patient that has got a PAD? No. Can you use aspirin and clopidogrel to treat a patient that's got a PAD to prevent them from having CAD complication? Yes. Now, which one is better, aspirin or clopidogrel? Studies have shown that clopidogrel is better than aspirin in protecting the heart in a patient that's got a PAD. I repeat, do not use aspirin or clopidogrel to treat PAD. You use it to treat CAD complications. A patient with PAD, especially with intermittent claudication, you want to use silazazole or penicillin. Okay, very important. So you want to give patient eye statin medication if they have PAD. Okay, smoking cessation. Don't forget, smoking cessation does not improve ABI, but it improves your endurance. Okay. Diabetes, when you improve your diabetes, your chances of developing PAD goes lower. Remember, every one increase in hemoglobin A1C will give you a 28% increase in PAD. Okay. Exercise, we talked about that already. We talked about this already also. Oh, after you've done revascularization, this is very important. After you've done revascularization, okay, you want to place the patient on the combination of aspirin and clopidogrel. Aspirin and clopidogrel are antiplatelet medications. They call it dual therapy. You want to place them on dual therapy after revascularization. So if a patient goes for angioplasty, otorectomy, stenting, bypass, you want to place them on dual therapy, dual antiplatelet therapy, aspirin and Plavix. Okay, but if they do not go for any endovascular procedure and they say pick one, which one is better, is your clopidogrel. Okay, this is what I was talking about. Penicillin improve rested deformability, lowers fibrinogen, which will lead to some kind of platelet, leads to some kind of bleeding. But again, it's not that bad. One thing I want to bring out here is that if you have a patient that has got a PAD and they have hypertension, the first line treatment, okay, for these people is ACE inhibitor. And the specific ACE inhibitor is, what's the name? I put it here somewhere. What's my ACE inhibitor? It's not here. I thought I did put it here somewhere. It's not here. What's the name? Ramipril. Ramipril has been shown to be really excellent in treating patients that's got hypertension and PAD. On the exam, if you ever see, a situation where you have a patient that's got hypertension and PAD, your first line treatment is your ACE inhibitor, okay, followed by your calcium channel blocker and your diuretics. Another thing I want to bring up here is DVA. I'm not sure you guys know anything about DVA. Okay. Before I go into that, sorry. Okay, right here. The best treatment for a patient when it comes to revascularization is bypass. That's a gold standard. So when they ask a question in the exam and they say a patient went for revascularization, when should you do a surgery on them, or when should you wait for surgery? You should wait at least 4 to 10 days for the body to get oxygenated. So you need 4 to 10 days. DVA is called deep venous authorization. What exactly is that? The DVA is pretty much when you use a vein, okay, and convert the vein into an artery, to increase circulation. And the reason why you use that is when a patient, they call it no option patient, when a patient is not a candidate for revascularization, okay, and the patient does not want amputation. So your last option is something called DVA, where you convert your great saphenous vein, so you convert your deep vein into an artery. And that's it. Now I'm gonna ask some questions now. Before I go to my questions, do you guys think this was a really good review for you guys? Does it bring it home?
Yeah, Dr. Sam, it was very helpful.
Okay, so let's go into some questions, blood vital questions. And this is what I'm gonna call on people. Where's my stuff? My blood vitals. Blood vitals. Let's do. I have let's do.
Can we have the slides, please?
If you want the slide, I could definitely send you a slide. No problem. I want you guys to pass. I want you guys to do well. I'll send it to you.
Thank you.
Okay,
I have no
thank
problem
you.
with that. Okay, I need volunteers. Who wants to help me out? Okay, who wants to do this one?
You're not sharing the screen, Dr. Sam.
Oh, geez. Okay, sorry. Let's share my screen. Do we have any third years here? Class of 2025? Anyone? Probably not. Probably not here.
I think some of them were before, you know.
Oh, yeah.
Yeah.
So let me see if I could share. Okay, can you guys see it now?
Yes.
Okay, good. Okay, so based on everything we've been talking about, okay, so what's your answer? Any volunteer? Our patient is going for neuroma surgery. That's a question. And they say on the examination, patient does not have palpable pulses. Okay. Capillary refill time is sluggish. Just based on that, no pulses, capillary refill is sluggish. Will you do surgery on a patient like this?
No.
No, I think you refer to the
Keep going.
vascular.
The ABI, okay, in the office is 0.55. Normal or abnormal?
Abnormal.
Abnormal. So which of the following is best option moving forward?
Vascular.
B.
C. Let's see if you're right. You're
No,
wrong.
no, B.
No, we said
B.
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 Oh, say D.
Oh, yeah.
D.
D.
What
B.
is right?
Yeah, boy.
No.
Oh, okay. You said B. Oh, B. Everybody agree or disagree?
Okay.
Agree.
Agree. Are you sure? Going once, going twice?
Yes.
Okay. And you are on the ball. You guys see that? You guys on fire. This is board vital. By the way, board vital questions are very close to what you're going to see on the board. By the way, FYI, it's not the same question, but it's similar to what you're going to see. So board vital is pretty good to prepare you. Okay, let's go to the next one. Let me make it bigger for you so you can see. What is the mainstay of non-invasive vascular study of venous insufficiency of the lower extremity?
A.
Someone say D. Okay, D. Okay. Oh, you're wrong. Who said D? What's the answer?
A.
Someone said C. I'm hearing C. Going once, going twice. Anyone? Nobody? Okay. Why do you say A?
Because for venous it's different. So a toe brachial index and ABIs would be for arterial, not venous.
Thank you, sir. Thank you, sir. Thank you. Thank you. Okay, let's go to the next one. Again, I didn't make this question. This is from your board battle. I'm literally going on the board battle. And this is saying, let me see, make it smaller so you can see. Come on. Oh, here you go. Okay. When evaluating the patient with PAD, okay, which of the following is the most consistent with the diagnosis? Let's do it together. Swelling of the knee that is provoked by activity. What is that?
Baker cyst.
It could be Baker's cyst. It could be arthritis, right? History or trauma or ecchymosis. Right? That's no basis on this. Systemic symptoms with possible skin lesion. Not really. When you have a tight calf pain, okay, what could that be? After every exercise. What are you thinking? But what's the diagnosis for that? Number D, what's the diagnosis?
Exertional compartment syndrome.
Yes. Who said that? Yes. Who's that?
It's helped with.
Oh, you are cheating. Cheating. I want the fourth here. Okay, exertional compartment syndrome right there. Okay. Okay. Can anybody agree is E or disagree?
Agree.
Agree. Abnormal capillary refill is your answer. Okay. All right. So let me go to my next one. The next one is Let me see. Okay, lymphedema question. Who wants to try this one?
I'll do it.
Yeah.
Gonna be E.
That's right. That's right. Cobblestone. Remember we talked about it. That's right. Good job. I'm gonna go to the next one. Sick of time. I want you guys to get out of here. I have some nice one for you. Make sure I cover everything. Okay, this one. Okay. I'm trying to make sure you guys get out of here. That's why I'm rushing a little bit now. That's not working. Show my stuff. Why is it not working? Okay, let's do this one. A patient who has been followed by many years with chronic stasis dermatitis and intermittent stasis ulceration begins to develop small white plagues of sclerosis within the hyperpigmentation of the hemocytin deposit. This is mostly likely what?
A.
How do you know that? How did you know
We
that?
just did it.
We just did it. That's right. You guys see that? Okay. I guess a good review. Let's go to the next one. Make it bigger. Okay, a patient presents with the ulcer with ischemic changes to the left foot. Okay, the ABI on the right is 1.5, 1.6 on the left. Okay, you're suspecting patient has calcified vessel. What's the question they're asking? Hold on, make it smaller. What test will you likely order on this patient?
A.
Why can it be B?
Because there's calcific sclerosis.
Why can
And
it be C?
Um, nah.
Nah, I agree. I like that. I like that. I like that. Why can it be segmental pressure?
Because you don't want to do ABI or segmental pressure if there's calcific sclerosis.
Who's talking, by the way?
Saida.
Oh, Saida, how you doing?
I'm well. How are you?
Good, good, good. Excellent. So toe brachial index, or you could do toe pressure. You could do SPP. You could do PVR, right? So, okay, good. Excellent. Which one is this one? Which of the following is recommended as DBT prophylaxis for a post-op patient who has not yet achieved hemostasis? Prophylaxis.
Is C.
On track.
A because they have not.
Wrong.
A
Yeah.
because they have
Someone
not.
say A.
Unfractionated heparin.
Why do you think it's A?
Because they don't have hemostasis yet, so you have to do anything that doesn't work with the chemicals of the blood.
Can I use, forget about the hemostasis, right? Can I use low dose unfractionated heparin, okay, for DBT prophylaxis?
Yeah.
Can I use low molecular weight? Yes.
Yeah.
From the Purinox? Yes. This from the Purinox, is really great in patients who's got to eat, like HIT, okay? It's a synthetic heparin. So the answer they're looking for is A. You know why? Because you have not yet achieved hemostasis. The patient is still bleeding. When a patient is still bleeding, you don't want to give him, heparin, okay? For example, if a patient has aortic dissection, can I give them heparin? What? No, you don't want to give
No,
them everything.
because
'cause if-
you'll
if
make them
they-
bleed.
Exactly. So what I could do is I could give them intermittent pneumatic compression. So when I do hematology, I'll go with this a little more. But the answer is A. Good job. Next one. Which one is this one? That's surgery. That's surgery. Let's leave that alone. Let's go to medicine. Okay. Good. This is a good one. Medicine stuff. Okay. Patient has a DVT. You elicit or calf pain with dorsiflexion of the foot. What's your diagnosis? What's your sign? Anyone? Someone say A. Wow. What's
C.
A? I heard someone say D. Wow. Now,
No, C, Coleman sign.
I'm joking with you. I want to make sure you guys understand. Coleman sign. Good job. Okay. Good job. Let's see this one. Which one is this one? Make it bigger so you can see it. This is a commonly non-invasive measurement used to diagnose PAD and estimate cardiovascular risk in patients with diabetes. Someone says C, is that correct? It's a non-invasive. Think about it, non-invasive.
D.
Can it be venous Doppler?
No, it's invasive.
No,
Venous,
venous Doppler is not invasive.
it's not invasive, but it's venous, not arterial.
Exactly. Exactly. It's not arterial. So that's out. Okay. Angiography,
Invasive.
invasive. Cardiac stress test.
Doesn't do peripheral.
Exactly. Do you guys get it why this is D? Yes?
Yes,
That makes sense or it doesn't make sense?
it does.
So cardiac stress test will kind of tell you if you have a cardiovascular risk. Yeah, that's true, right? But it has nothing to do with PAD. Angiography is invasive. Venous Doppler is for vein. So the only answer is ABI. Let's do. Okay, what do you think? A patient with ABI of 1.4, non-compressible. What does that mean?
Classified vessel.
Oh, B? You think it's B?
D.
B?
Yes.
Anybody else? Agree with B?
C.
Anybody else agree with B? What is the venous sufficiency? We know it's not that. It can't be venous sufficiency. What's a cutaneous calciphylaxis? What's that?
Calcification of the soft tissue.
Exactly, of the soft tissue, especially you see that in what? Patient with kidney disease, soft tissue. Okay, when you have ABI 1.4, what is that measuring? Soft tissue or artery?
Arteries.
Senya, what do you think?
What do I think the answer is, or
Yes, answer is.
a B?
Say B.
Mhm.
Uh,
Because it's end-stage renal disease.
Mina, what do you say? B, Mina?
C.
C, as in
As in
Cynthia?
Sam.
It's about this C.
Yes.
Okay. Senya, why do you think B is correct?
I mean, B is only caused by the end-stage renal disease, so that's what drew me to it. I have not done this question though, so I'm just guessing, but That's my
Let's read the
rationale.
question again. Let's read the question again. An ABI 1.4 is significant for non-compressible vessel, usually seen in type 1, type 2, patient with end-stage disease and peripheral neuropathy. They're telling you, right? This is caused by the following. It's caused by what?
Classifications, obviously.
Classification of what?
The arteries.
Exactly. Why were you saying B?
Because of the end-stage renal disease. I didn't read the question right.
Exactly. So that's fine. That's fine. So be careful on this exam, right? So when you see end-stage disease, yeah, you're going to see cutaneous calciphylaxis. That's for the soft tissue. Okay. But when you're talking about ABI 1.4, he's talking about the artery, which is carcinosis of the tunica media. Okay. Does that make sense?
Yeah, I just read the question because what am I doing?
Got it. Let me do some DBT questions. Okay, what do you think? What's the answer? Which of the following is not part of the Butcher's triad?
D.
B. Somebody say B.
D.
D. Everybody agree? That's right. Good job. Good job. Let me see. What else do I have here? Okay, this one's a little lengthy, but we can make it work. So read that and give me the answer. I mean, if you just go to this last question, the last sentence, what are the available non-invasive vascular study for this patient? Non. Can it be D?
No,
No.
C and D are
Can it be C? No. Can it be B?
no.
So what's the answer?
A.
That's right. Okay, let's keep going. I'm almost done. Oh, look at this one. Ah, that's a good one. Which of the following toe pressure is classified as severe limb ischemia?
A.
That's right. That's what I'm saying. You got to memorize this. You just got to memorize it. Good job. Look at this one. Oh, this is the wound. But what do you think? Let's give it a shot.
D.
B,
D.
D. Everybody agree? So what's the Wagner classification? 1, 2, 3, 4, 5.
4.
4. Good job. 4. Excellent. That's surgery. Which one is this one? Let's see. No, we did that already. Which one is this one? Okay. Anyone want to try this one? So let's just start with this one. On the right lower extremity for this heel wound, the dorsalis pedis pulse was found to be biphasic, and the PT was found to be monophasic. Good or bad?
Bad.
Bad, right? From the treatment options listed below, which would be the most appropriate choice? Should I go in and do excisional debridement?
No.
You remember I was talking about the angiosomes, right? What are the two vessels that supplies this area?
ET and peroneal.
PT and peroneal. And this is telling you the PT is monophasic. Okay. By the way, 2/3 of the heel is supplied by PT. So this is, we have a problem here. So I'm not going to do excision debridement. Can I put a wound back on this?
No.
Absolutely not. Can I apply a skin graft on this?
No.
So what will I do? Right? Makes sense, right? I mean, if you read these questions, they're pretty straightforward. Oh, this is a good one. Oh, this one was a tough one. Let's see who's going to get this one right. So you have a patient that's having numbness in the buttocks area. What does that mean? What's the diagnosis? Anyone? Numbness in the buttocks area. Come on. Pain and numbness in the buttocks area. History of PAD. What type of PAD is that?
It's high up.
I know, but what's the name of the PAD? What type?
Is it serial claudication?
Say it again.
Serial claudication?
Right, it could be that's right. It could be pseudocaudication or it could be intermediate claudication. Thank you. That's what I'm trying to get at. Okay. So that means you have an occlusion up high. Okay. Anyway, it states that it can walk about 40 yards, but then experiences pain and numbness that pretty much goes, to the lower extremity. So based on that, that's telling you it's not pseudocaudication, that is intermediate claudication. Agree? Right? Patient is diabetic, is taking metformin, and he smokes, for 40 packs in a year, history of tobacco. So the question is, A, which of the following is correct? Smoking sensation is associated with improvement of ABI, true or false?
False.
Right. Exercise program we improve the ABI.
Nope.
Nope. Statin therapy does not improve claudication.
Nope.
Nope. Because statin will improve claudication, right? Remember? Aspirin improves claudication. I'll be upset if you get this one wrong.
False.
Nope.
False. Aspirin will improve CAD complication.
True.
True. Clopidogrel is better than aspirin in improving CAD complications.
That's right.
That's right. So E. Does that make sense? Okay. Let me see. What else we have here? This one's easy. I'm going to do one more and I'm going to end it. Okay, this is the last one. We want to give it a shot.
B.
Guys, I want to say thank you so much for listening to me. I hope you guys have learned something. I hope this really helped you guys out. Please go review your PAD stuff and your venous stuff. And I wish you good luck. And I'll see you guys next time.
Thank you, Dr. Sam.
Thank you.
Thank you.
Thank you.